of disability-free survival, let alone survival itself, depends very much on where you are born, in which country, whether in the high-income countries or middle-income countries and low-income countries, where you have home birth and care at home for the low-income country, or is it one where there's a facility of births but limited space for those births. My talk will mainly concentrate on high to low middle income countries. Malaysia is considered as a high middle income country, and I'll show you some of the other countries which we'll be discussing. So as an overview, I thought we'll start first with the costs from the perspective of the policymakers. In developing countries, much of the budget, in fact, almost all of the budget comes for the government hospital, which attends to most of the patients, comes from the government, the Ministry of Health, that is, and so how they give the budget to us working in government hospitals depends on their perspective. And for that, we have to understand what is the global burden of prematurity and neonatal mortality as seen by public health as a worldly concern. And do we, as a country, need neonatal intensive care to reduce neonatal mortality? That's what the policymakers would want to know. Now, then Malaysia has got NICU, as many of the high-income, middle-income countries. And so we'll talk about the costs of NICU care in these countries. And of course, the costs of the intensive care to the parents and ethics around the decision-making when parents cannot afford the private care. So where the policymakers are concerned, they have to meet the targets of the Sustainable Development Goals that was developed by United Nations in agreement with most countries there. And where we are concerned, it is the Development Goal 3, whereby it's on good health and well-being. And by 2030, the goal is to end preventable deaths of newborns and children under 5 years of age. And to do this, the sub-targets are to reduce neonatal mortality to as low as 12 per 1,000 live births. Of course, some countries have already reached that. And to reduce under 5 mortality to lower than 25 per 1,000 live births. And for countries with neonatal mortality rate of more than or equal to 5, the target is to reduce the neonatal mortality rate by 50% from the year 2015 to 2025, leaving you another 5 years to sort of reduce it further, if possible, to below 5. And once for those countries which have neonatal mortality rate of less than 5 per 1,000, is to eliminate preventable preterm deaths altogether. The key word is preventable. To focus on equitable care for all and to have a good quality of life to minimize long-term impairment. So this is what the policymakers they want. We who are working in the neonatal care area have to use this in order to get budgets from the policymakers. And as you can see, as the under 5 mortality reduces for any country, and this is generally true for the whole world, as your under 5 mortality comes down, the neonatal mortality becomes a more important part of the deaths, and especially early neonatal mortality, meaning before the age of 7 days. And if you look globally, under 5 deaths, the yellow section shows the neonatal deaths, and 40% of deaths are neonatal. And preterm births comprise 14%. The rest are related to asphyxia or sepsis. For Southeast Asia, where we are sort of concentrating a bit today, it's even a larger component of under 5 deaths is due to neonatal deaths. So 52% with 19% preterm complications. And if you look at our area of focus, the preterm birth rate is 10 to 14 per 1,000, 10 to 14%, sorry. And except for Bangladesh, which has a higher rate, and Indonesia and India has actually come down. They were previously 15 to 20 in 2010. So this is 2014, right? And so when you look at the total number of preterm babies out of world numbering 14 million preterm births, this area in dark blue, this area that I circle here in dark blue, including Nigeria, it contributes 41% of total live births in the world and 44% of preterm births. So you can see that this is a huge area of concern in terms of reducing total live birth mortality as well as preterm mortality. So do we need NICUs to reduce neonatal mortality in all countries? So that's, here, this is a study done by Professor Joy Lawn, who's actually a director of your London School of Tropical Hygiene and Medicine. I'm not sure whether now she's in South Africa. And this was published in 2005 and still applies today, that if your neonatal mortality rate in your country is more than 45 per thousand live births, then the major part or causes of death are due to asphyxial causes and sepsis. As compared to countries where your neonatal mortality rate is less than 15 per thousand, then preterm forms 40% of your deaths, followed by congenital anomalies. So if you look at the countries that we are sort of discussing today, and this is according to, this is GDP, I'm not sure whether can you see the heading? This is the GDP for the per capita, and we're going downwards, right? And then this is the neonatal mortality rate about a year, 2019 or 2020. Now, Malaysia is here at 4.6 per thousand live births for our neonatal mortality rate. And China is here. China successfully halved their neonatal mortality rate from 2010 of 8 to 3.9. India has also reduced, I think it was 25 per thousand. So now it's 21.7. So you see these countries here, a lot of them are in the South Indian continent, except for Laos and Myanmar. So these countries struggle from other social and health problems, and in fact, underweight is quite a major problem for children. But we won't talk about that today. So preterm births, when you look, what is the component of preterm births? You see that a large number of preterm births are actually late preterm and moderate preterms. As compared to a very small number, this is in thousands, right? So there's still about 1 million or so extreme preterms, but the majority are actually 32 to 37 weeks. So they don't really need NICU care except CPAP and effectively, right? And if you look at the percentage of deliveries that are attended by skilled personnel in the year 2014, 100% in Eastern China, Asia, mainly China, would have deliveries attended by skilled personnel as compared to Southern Asia, which is 52, and Southeast Asia is somewhere in between. And if you look at the countries' neonatal mortality rate being high, those countries have home deliveries without proper skill attendance, right? As compared to those with lower neonatal mortality rate, where 98% are institutional deliveries, and with skill attendance, 99%. So therefore, if you ask, and if you look, most of the deaths are on the first day of birth. So if you ask the policymakers, how are they going to reduce neonatal mortality and even preterm mortality, especially for the larger preterms, which are the major component of preterm births, is to encourage people to go for more antenatal visits, because they found that by having gone for antenatal visits, it's more likely to deliver in a health facility, and to reduce poverty, because if you were to increase, even within the country, there are variations in neonatal mortality rate, being the highest among the poorest, of course. And if the neonatal mortality rate for the top quartile of your population in terms of income is to be the same for the whole country, that would prevent 500,000 neonatal deaths in Bangladesh, India, and Nepal. So reduction of poverty is one of the things that the policymakers must do to improve neonatal mortality rate. And to have community and outreach-based programs which will reduce the delay in recognition of illness, accessing care, and reduce delay in provision of care once it is at the health facility. As a result, the Born Too Soon report for preterm babies have come out with this are the management for countries with high neonatal mortality rate, basically a preconception care package, an antenatal care package, and anti-smoking, as well as management of essential newborn care for all term and preterm babies, good neonatal resuscitation, breastfeeding, kangaroo mother care, and management of the larger preterm babies using surfactant and CPAP. The antenatal steroids to prevent or sort of like improve our outcome of the preterm baby. If you can delay it for a little bit longer with tocolytics, that we find good. So only one sentence, which is comprehensive neonatal intensive care, where capacity allows for this is looking broadly from a policymaker point of view for countries with high neonatal mortality rate. And those countries that managed to reduce their neonatal mortality rate by half, which is the MDG goal actually from 1990 to 2015, if they're able to reduce their neonatal mortality rate, they found that those countries have had a national focus on improved obstetric and neonatal care with systematic establishment of referral systems and improve the capacity of the neonatal, not necessarily NICU, can be special care units and staff and equipment with larger budgets, obviously. So neonatal mortality rate can be reduced from more than 45 per thousand live births without NICU facilities. But once we get down to countries with neonatal mortality rate below 15 per thousand live births, then you do need neonatal intensive care, because then you're looking at that group of babies which are the preterm below 32 weeks and the ill ones who may be in PPHN and all that. And we find that the costs to reduce the disability adjusted life years will escalate tremendously. The cost increases tremendously for a small amount of improvement in your disability adjusted life years as compared to the wide amount, really good, cheap improvement of disability adjusted life years by 25 years just with less than $200 million. So now we come to Malaysia. So the point of what I was trying to say is that for babies that are for countries which are still poor, low GDP with high neonatal mortality rate, the aim of the policymaker is not to build NICUs, but to improve the public health system and to improve, to reduce poverty. For Malaysia, we are high middle income, and this is our figures of neonatal mortality rate, infant mortality rate, and under 5 mortality rate from 1990 to 2018. Actually, all these were compiled more, the data was collected more particularly after 2012, because that's when you have to show off to the rest of the world. And we found that with better data collection, not missing so much data, we actually had a rise in our neonatal mortality rate, but thankfully it was not that much more. And as with most of the countries, this sort of pattern, you find that 40% of the deaths over the years, it hasn't really changed that much, are due to preterm births, although it looks like we have a larger proportion of deaths from congenital anomalies as our asphyxia and our asphyxia and infection rates come down. This is just to illustrate to you that in the 1990s, we were having relatively high mortality rate, right? So we did not look to resuscitate babies who were below 1,000 grams. Unless they were severely growth retarded, they really only needed minimum support. So it was only later, like in the late 1990s, that we started doing more ventilating them. And now we are ventilating until most centers are ventilating to about 25 weeks. Some may go lower, depending on the individualization of the patient. For the, so because at that time, our performance for 1,000 to 1,499 grams was still not very good. And we were not, as with most developing countries, the gestation at that time in the 1990s was not that accurate, right? Because now we use ultrasound for assessing gestation in most cases. So now we do have the data in gestational age, and the blue and the orange are the curves of the survival versus gestational age in 2005 and 2007. So on average, there's a 10% rise in survival rate for across gestation. And we basically have not much problem with the 30 weeks and above. There's variable outcome in the NICUs for the extreme premature babies. So what is the cost of NICU care? We'll start with the developed countries first and general basic first. Excuse me, just choose them. Of course, the first one is direct cost. So it's like your initial hospitalization cost, the first time you're admitted until the day of discharge. Health costs on follow-up, which would be actually the majority of it is the first year after discharge. And then costs associated with morbidities from preterm complications like cerebral palsy, chronic lung disease, and so forth. Indirect costs are what is borne by the parents and family, actually, because say like if the child is has learning difficulties or even needs interventional care from the beginning, we don't have that many interventional care programs within the government setup. And I forgot to mention, and I will later in more detail, that most of the preterm babies are actually managed in government facilities. And most of the costs are borne by the government. Unless you are a foreigner or you have been referred in by the private side, but even then it is still only, you pay only for the hotel costs, which is about 50 ringgit a day. Right. So the educational costs is borne by the parents. The rehabilitation costs is hard to find, mainly only in the larger towns and mainly in private. Government has, but it's like, you know, the appointment is like once every month or so, and it's quite hard for parents to come regularly because there's also, you have to spend a whole day there because of a long queue. Additional family expenses you would expect. When the child is in hospital, they have to make many trips to visit the child, and one of the parents will probably not be working. In addition, there may be other costs like wheelchairs and other aids. And then the parents, there's a loss of productivity from the parent who ends up spending, giving up a job to look after the baby on discharge. And even during hospitalization, the parents are not frequently absent from work. So these are the indirect costs, which are not found in many of the studies. And I just put up this chart to show you that, as we all are aware, that the costs of the preterm care in hospital varies inversely with the gestation. So in Canada in 2005, 2006, the years, it was about 120,000 USD and very cheap for the term baby. Now this is in UK. These are old studies, but it's quite hard to find newer papers which look comprehensively at the costs. So this one is looking across from various gestations, and this is the length of stay. Length of stay is very important because actually at the end of the day, the cost goes up according to length of stay. It's almost a standard fee for the baby per day. Although a large chunk of the cost is actually in the first week, as you know, And then after that, it sort of like stabilizes and it's about the same. And so it's a matter of how long you stay, and of course, the cost will vary with the centers. If you are not as, your baby has a lot of complications or as NEC, these surgical procedures, then the cost will escalate, right? So the neonatal cost is about $202,000. Yeah. Okay. So that's for a 25-weeker. As compared to a 37-weeker, it's $1,700 per case. But if you were to look at the total amount of money that the industry has to foot out, either whether it's put out by NHS or whether it is by the parents or the insurance, a large amount of the cost is in the late preterm. Why? Because the numbers are in the late preterm. As we know, late preterms are not without problems, and many of them also stay for at least a week, if not more, to establish feeding. And then the mother's cost for the taxpayer is also more because of the larger numbers, right? So if you're looking at cutting down costs as a system provider, then it's actually to look into any unwarranted late preterm deliveries being induced unnecessarily, because that would cut down a lot of the costs. This is the only study that I can find by this very good economist. He's done a lot of papers on neonatal and societal costs. He's done almost all the studies, many of them in the preterm are done by him. You have you see health and social care, education, parental expenses, lost productivity. And for a 27-weeker below, it's £151,000 as compared to term baby. So it's like 3 times as much, right? So these are borne by society, whether it's by parents, by insurance, by the educational centers, by employers. This is part of the costs of looking after preterms. So for Asian countries, all those costs that you see post-discharge are borne by parents. For NICU costs in Asian countries, unfortunately, they're quite hard to find. Many studies have been done in India, and I've got my Malaysian study, and China had a few. So, and we can't really compare between them. It's just to give an idea, and then the later studies will build up from there. So there are methodological differences in the costing, because some may be using hospital charges instead of the actual costs. Some may just do rudimentary costing of consumables. Some actually do micro costing according to the disease-related group, right? So if you are just comparing developed countries and developing countries, or you're even looking at within the developing countries, what are the differences? Because we have consumables costs, which are variable. And I think they would be cheaper in India, I think. And then we recycle our consumables, those ones that do not come into contact with body fluids. The intensity of care, and see, as time goes on, as we advance in our neonatal care, that there will be more intensity of care. For example, now we offer them high frequency ventilation, and we have hypothermic therapy for the term. And we have more. We tend to do more, and we end up using more consumables. And we have pulse oximeters where we didn't have it before. We have EEG monitors, which we didn't have before. So all these adds up to the cost. So if you were to compare costing studies in the 1990s as compared to 2020, it would be different. So the range of patients and treatment given, some studies only look at term babies with occasional preterm baby. Some look at preterm babies that are only up to 32 weeks. So of course that would shorten your length of stay and impact on the cost. And some countries will have lower emolument, and then the staffing ratio may be different. So all these affects the cost difference, to cost to the end user as well as to on our studies. Majority of studies only do the initial hospital costing in Asian studies, right? And then when we compare them, actually we're supposed to use purchasing power parity, which means that we compare them all to a certain year based on inflation and based on US purchasing power if you were to use the USD. So I want to show you now the study that was done in Malaysia, and it's like 1999 when we did it. And during that time, we decided not to include the ELBW babies because we were not being very active. So therefore, the probability of survival at 1 year would definitely be variable among the 5 centers that we did. These are all state hospitals, 333 babies. And the majority of them were around, the mean birth weight was about 1,250, somewhere there. And mean gestation is 31 weeks. The mean length of stay was 36 days. And the overall probability of survival was 78%. But you can see that there's variable survival, 91% here as compared to 69%, right? So, and even 52% here. You see, at the end of the day, we all as neonatologists are at the end of the baton. So it depends on the parents, whether they received good antenatal care, whether they have been, sought treatment early, whether they had a chance for antenatal steroids. So all these affects the survival of the babies among the various centers. They're all in different parts of Malaysia. So how did we actually cost it? This is just to give an example because I'm not going to go into detail for the other studies. So for the consumables, we took 8 babies from each hospital and we actually micro-costed everything that you use in terms of consumables. Then for the overhead, we will count the utilities and divide that as a proportion of the number of patients that were in the ward compared to the whole hospital. Staff, we counted according to full-time equivalents and we used their pay. And so that would be the total recurrent costs. For equipment, building and land, we use the capital costs with deflation, and we apportioned it according to the space of the NICU relative to this land area of the hospital, the built-up area of the hospital. So with that, we got cost per inpatient, which is about 3,104. And the probability of survival at 1 year, we saw that it's not 78. So when we look cost effectiveness ratio, just for information, it is the cost per patient over the probability of survival. And that probability of survival could be at 1 year, great discharge, and so forth. So that means that you take all the costs of the patients that you have divided by the number of survivors that you have. Means that if you're cost effective, you will have a higher survival rate and you will have a lower cost. So the ones with the highest cost effectiveness ratio actually means that they spend the most money and they had the least survival, right? So on the mean was 39, our cost effectiveness ratio was 3980, and it was relatively cheaper compared to American studies which were done around the same time. Partly because our emolument is actually very, very low compared to American emoluments. And our capital costs also less. So if I were to translate that to 2021, assuming inflation only of 3% per annum, that means you're looking at, it would cost now 5,130 for a 30-day stay, which is 170 per day. And for extreme preterm 26 weeks, our average length of stay is 100 days. And that means with a survival rate of about 50 to 60% now, take 50%, that means our cost effectiveness ratio is 34,000, which is actually very cost effective. If you were to sort of like fight with resources with your adult side, for NICU budgets. Our NICU is so cost effective compared to hemodialysis, coronary bypass, and even adult ICUs. Is considered cost effective so long as you less than about 100,000 per patient. So just to show now the NICUs, and I'll just show you where they are located. This is Peninsular Malaysia, and this is Malaysia on the Kalimantan side. This is on the Indonesian island here. So there's Kuala Lumpur, where I work, and Seremban further now. I'll show, these are all the NICUs that I'll be showing you. This is on the East Coast. This Kota Baru Hospital and Kuala Terengganu, and then Kuching these are all state hospitals, and this is a district hospital. But because of the geographical displacement, the district hospitals have to be big because it takes so long to travel between hospitals. So this is the New Women's and Children's Hospital, which I retired just as about to open, so I didn't get a chance to work there. And this is the semi-intensive area. There are 2 more special care units. And this is the hospitals in Seremban. And this is in Kuala Terengganu. This is relatively new hospital as well. And this is the older hospital in Kota Baru. So you can see that the old hospitals have got a lower ceiling and the pipes are exposed as compared to new hospitals. This is Sandakan Hospital. This is the district hospital. And this is this is the ELBW part of the NICU in Kuching. So we have the government hospitals, which are actually well equipped, relatively speaking. Although if you ask any of my colleagues, they'll say, no, we don't have enough equipment. But compared to other countries, I think we are relatively well equipped. Then Malaysian private hospitals, they are more for level 2 care. A few will ventilate to level 3, and they don't really have a lot of beds because it's so expensive. So the ones that need level 3 care will usually be transferred to a government facility. And this is an example of a new level 3 hospital in Glen Eagles, a private hospital in Sabah. So what happens then to those who are in private hospital, and they can, it costs 10,000 out of pocket for the parents to be in a private hospital for 1 day. So that's 10,000 ringgit, but you have to think in terms of the ringgit here. So that's like maybe 3 times the amount of monthly salary for some of our patients. We encourage in utero transfer for those below 32 weeks, and then the ex utero transfer for above 32 weeks, because sometimes they may be able to afford just the 2-3 week stay. And if not, then they have to resort to crowdfunding if they can't find a bed in government facilities, because now our government facilities are also very short of beds. Right now, I'm going to show you the cost of neonatal care in other parts of Asia, and I don't have any experience of working there, and all I have is from reading from the journals and from the internet photos. So this is Marka Hospital in Delhi, and I presume this is a special care nursery. And this is King Edward Memorial, which is a government hospital, I believe. And you can compare that with the private NICUs, which are very well equipped. Really, there's no much difference from other developed countries. So in a sense, this is a sign of a developing country where you have sort of like 2 extremes. So the base cost for neonate and per bed day in SCN units was done in 2010. And basically it is very cheap. These are in Indian rupees, but it's equivalent to 20 USD per day. And if it's in private, it will be around 90 USD with the median of 272, and these are mainly SCN type of babies. So with the, I think, Millennium Development Goals, the Indian government actually spent more money to develop a network of special care nurseries. And this, maybe it looks like a big number, 454 USD, but it's actually only 0.8% of India's health spending. So then this is done in a private, no, this is in Ames University, if I'm not mistaken. And even then, the NICU was only 125 USD per day into the year 2003. But if you look at the breakdown of the figures, if you translate it to 2016 purchasing power costs, it's actually quite a lot. It's 19,000 for ELBW, but of course it's cheap compared to 200,000 pounds in UK. But there were very few, about 16 babies only out of 200 over babies in that study. So just to give it a general overview. It's very interesting that India is very innovative, and they've come up with a lightweight CPAP therapy device, which can be carried and is only 5 kilos. And this can be used in a non-NICU setting or to transport babies to an NICU that they can get. And then I saw there's a low-cost incubator, which the only thing that is like cardboardish is the outside. The inside are all the equipment that you need in terms of electronics and stuff. So this is only 200 USD. So I think that the Indian engineers are very innovative, and I wish that they would come and sell some of it to us too. This is neonatal units in Pakistan. This is a Lady Willingdon Hospital. And then there's the private ones, which are actually funded by donations. And this is Aga Khan. So Aga Khan is like totally different from the rest of Pakistan. So this study was the only study that I could find on costing in Pakistan at the time when I was looking in 2006, last year. And this is an old study. And at that time, it's mainly for term babies only. Of course, the methodology is a little bit different. And the situation that was described in this study was that the babies were term babies, and they were 2 or 3 babies in one cot. And I think it was a fairly large cot, you know, the type that you would hold the babies post-delivery. Of course, the ones who were ventilated, and they did ventilate a few, they were mainly term babies with asphyxia or sepsis. And those ones were in very few beds, like about 4 or 5. And it was really not really costed inside here. In China, since 2010, there's a new insurance scheme where everybody pays about 15 to 45 USD per year per head in a family. And it covers 99% of rural birth population, and it reimburses up to 50% of the total medical care costs. But even 50% is still a lot of money to some. So you can see here a huge number of babies that are just in incubators. I mean, it's just rows and rows of incubators, just rows and rows, even though everybody can have only 2 children, but it's just many. And the cost is roughly about the same as Malaysia for preterm more than 28 weeks, and this is in 2010, right? So actually they are cheaper than we would be in 2010. And this is the only literature that I can find which actually talks about withdrawal, where the parents actually 50% of neonatal deaths are from medical withdrawal, because the parents are worried that there's, you know, even the Chinese here in Malaysia, they will, they do not want babies with handicap. And then they can't afford it as well. So, and if you have a handicapped child and you have limited number of children allowed, then you cannot have any more normal children. So they will withdraw. So in Malaysia, we wanted to see, and we also did it, this survey in Indonesia and China through our networking, and to see what were their opinions about when they will start to resuscitate, at which threshold for viability or at which gestational age, and what would be the reasons for them to continue or cease treatment. So you find that majority of our Malaysian neonatologists will not ventilate below 23 weeks, but there were 2 in private who would. And then some will start at 24. They would proceed with 24-weeker. I know these 2 are from private. I don't know the rest where they are from because I spoke personally to them. The rest, you see that there are variable points at which they would start treatment. That means they wouldn't be active for below even 27 weeks for 11 of the neonatologists. When this was done, this was in the year 2015. So it all depends on which center you're at, what is your outcome at that center, what has been your experience, what is the sort of patients that you get. Are they the type who are not going to come back for follow-up? Are they the type that the child's going to die of malnutrition later on? And that's what happens in Sabah. So all those babies in Sabah that are less than 1 kilo will not find their way to the main center in Kota Kinabalu, the state capital, because the journey itself will tip them off. And then after they've gone back, some will die of neglect. So each neonatologist actually has some decision to make as to how far they will go for which gestational age, and how they would counsel also depending on individual parents and their families and what resources they have. So the factors which influence decision to initiate resuscitation or withhold care in the extreme preterm, you find that for Malaysian respondents, cost was not an issue if they were in government. Because we have been lucky so far, but it won't be for long, that we just manage as we think we should and worry about costs later. Whereas the private neonatologists will be very worried about costs from the word go. Some will not ventilate below the 23, 24 weeks because they are worried about the prognosis. And this is very much the case for all 3 countries. But you see that in Indonesia and China, cost is a major issue. So we have the ethical dilemma of that the child could live, but then we're balanced with the overall life burden for the child and family, especially when they have their costs post-discharge. And if your pram babies have full of complications and have a high chance of cerebral palsy or mental delay, then it would be a big burden for the child and the family. So so is it ethical to allow cost considerations to dictate life or death? Is it ethical to subordinate the care of an individual to criteria for maximizing social benefit? Those are the dilemmas we have to struggle with. One on individual basis and one from the policymaker and the head of the unit. And from the parents, there's also the emotional cost, because we find that the mothers of handicapped survivors will not have any children because they already cannot cope. And if you have limited beds, then you will compromise care of larger, more mature infants if they can't find their way into your NICU. They can be term and they can be ill, but they have no more beds. So when it comes to decisions for withdrawal or withholding in the ELBWs, actually, their chances of survival in the past have also been dependent on our selection bias. And means we may decide, okay, we are not going to try hard for this one because of poor maternal outcome, or we're going to try very hard because it's a bad obstetric history. The referral bias, I wouldn't send to that hospital because 100% of the babies die, that sort of thing. I'm just saying. And of course, the chances of survival is very center dependent. Generally, it's about getting more even in Malaysia, but it also depends on the area of which it drains, what sort of patients you are getting. Those with good antenatal care, those with a lot of teenage mothers, very high preeclampsia rate in the area. And in the 1990s, we were using a patriarchal approach. We would just say, sorry, we don't ventilate below 1 kilo, or we don't ventilate below 28 weeks. But now we are sort of like more shared decision making, and we love it if we manage to get antenatal counseling before the baby is born in the difficult cases. So how do we do it? I mean, like, it is a big problem to actually withdraw care once they're on ventilator, if there have been no antenatal counseling, because the parents don't have to pay for the ventilation care or the NICU care if they're in government hospitals. And of course, to them, the life of the child is of utmost important. What is it? Why you want to withdraw care, right? So if they don't understand, or they have social, cultural, religious values as life is valuable, and this is a son, and this is the only son that the family has, no, there's no way, even though we know that we are ventilating and prolonging death. So it actually is difficult both ways, right? Because some babies we know that will not survive, but the parents will still hang on. And then there are some, like for example, I remember an Indonesian mother who could not afford prostaglandin, and who could not afford the operation in our National Heart Institute. And she just says, take off everything, I will take my baby home. So in those days, we let the parents do that. But now we will try crowdfunding, or if we think that the prognosis is good, then we'll try other means to sort of help the parents. So NGOs and crowdfunding do help to get some money for the foreigners where the bill really escalates very fast, because in Malaysia it's like first class charges for the foreigners. Okay. So I think I just want to mention this last bit here. That rather than withholding care from the extremely low birth weight babies or the extreme parents, we should also look into how we can improve our level of efficiency, because there's such thing as what we call comparative effectiveness. Means that with this, if all our intervention measures are efficient, then we can get more improvement with the same amount of bucks, same amount of money, okay? And they have done studies which show that variations which increase costs without improving outcomes, such as the days of ventilator use, overuse of antibiotics, overuse of laboratory tests, overuse of vasopressors, and sedation. I'm sure we've all had that experience. The cost reduction strategies need to reduce the intensity of care and the duration of the NICU stay. So this would be our strategies in terms of, if you look at the country as a whole, you strengthen your public health measures, you reduce the number of unwarranted deliveries, and you strategize as the head of unit, or as you are managing a patient, how on your unit, how to reduce unwarranted intensity of care. Sometimes it's best to do less, right? And to reduce the duration of hospital stay by being, let's say, better with the infection control, faster in extubating babies who really don't need to be ventilated anymore. The equitable government resources for perinatal health care, which we have to fight with the adult intensive care services, and legislation to guide limited embryo transfer, which is also happening in Malaysia, so that there are limited ART cycles. Like financial support for limited ART cycles. We don't even have any financial support for ART in private. If you want cheaper, then you go to government hospital, but a long queue. So I think I will finish there, and you can just see it's not, I think I'll leave the time for questions. Mainly to say that the active care of the extreme preterm is a decision that needs to involve the society, the families, and the professionals. And if you know John Lantos, I'm sure you've heard his name because we just had this ethics module, that the success of NICU should not lead us to see it as the only solution to improve infant survival, and that we should constantly remind ourselves that we need so much intensive care, probably because of political, medical, and moral failure in sustaining an epidemic of prematurity. Thank you.
Thank you so much, Irene. That was absolutely amazing. It's certainly taken me back to my roots, and reminded me of the challenges that we faced as clinicians, especially with the limitations. I mean, having the resources was never the problem. The question obviously was how we manage those resources for so many babies. And as you've correctly mentioned, I mean, for us, when I practiced, in my hospital, which was a level 2 unit in India, we were in a situation where we just could not manage the volume of babies. So we agreed that to produce the best outcomes, we would only resuscitate above 28 weeks, because actually it became unfair to resuscitate smaller babies with poorer outcomes, which meant that beds are blocked for longer. And actually, the survival and outcome for us discharging babies below that gestation was so poor. We'd have a baby at 29 or 30 weeks who's bed blocked, who can't then take up a space, can't get a CPAP space. And, I think those were some of the hardest days about making decisions about who was the baby that was most
Yes.
likely to survive.
Often you feel like you're playing God.
Can I ask, Irene? So we have a few questions. So we've got a question from one of our nurses. So in terms of nursing care and managing neonatal staff and training in Malaysia, what does neonatal training look like from a nursing perspective and a medical perspective?
There are neonatal training courses for nurses in the government school of nursing. And the private hospitals also have their neonatal nurse. Would say that it's more for nursing training. When they want to send their neonatal nurses their nurses for further training, they will send to the government neonatal training school. So we all get involved in training them as well. We go and give lectures, and they come to our NICUs for tagging, and they also actually work in the NICUs with a mentorship with the existing neonatal nurses. Our ratio is actually very bad. We have 1 nurse to 4 intensive care beds. The best is 1:2.
I mean, I'm going to be honest to say that at the moment in the UK, we're only able to achieve 1:2. Even with our level of staffing, and I mean, we're a 24 intensive care HTU unit with about 150 nurses. But the challenges for us, we've never been able to achieve a 1:1. So I think that's fantastic. In terms of kind of length of training for a neonatologist to become a consultant in Malaysia,
for neonatologists, once they are a pediatrician, then they will enter a fellowship program for 4 years. 3 years. And but many of them have already done like 50% work in neonates while they are training to be a pediatrician, because actually outside the National Referral Center, many of the main subspecialty in the other hospitals are neonatology. So they are doing neonatology as in NICU care as a medical officer in pediatrics from the get-go. So our minimum requirement is they have done 1 year as a pediatric medical officer in NICU. That's to pass as a pediatrician. And then after they've got their membership in pediatrics, then they will opt to apply for a 3-year course, a 3-year neonatal fellowship training. After which we, at this moment, have an exit exam, written exam.
I've got a question from Gautam Gopalakrishnan, who's one of my trainees. Gautam, would you like to go ahead?
Yeah. Thank you, Anu. I would just like to thank Dr. Cheah for an excellent presentation. And my question is, how do we counsel a family of an anticipated extreme preterm who have financial hardships, in which they say that they would not be willing to, have baby because of many financial reasons, or they may not be able to take care of the hospital costs, even though the insurance may not be available. And once we explain to them the child's disabilities later, and they may not have access to rehabilitation programs, and once they say that they will not be able to take care, how do we go about and making them understand? How do we manage those cases in case of financial burdens?
You mean that if right from the word go before they have delivered?
Yes. If they have an anticipated preterm delivery, say at 28, it could
okay.
say
Well, we
28,
would have
29
to.
weeks.
So far, we've never had that sort of situation. You know why? Because they don't have to pay for the whole hospital care in government hospitals. And if they were in labor at 28 weeks and they had been on follow-up with the private side, so at that moment, which is unlikely in this sort of scenario because they can't even afford, much from the word go. So for those type of patients where they are generally cannot afford private at all, they would just deliver in government hospitals. And basically we would do full steam ahead as with all the other mothers. If let's say at 28 weeks during our antenatal counseling, they say that they can't bear the cost of rehabilitation, education, etc. We have never had that question because we don't really bring it up, I guess, because we know that they can't afford it anyway. So they would be following up with the government hospital for rehabilitation, and they would just attend normal school. If they need to have interventional services, they will also attend the government. So basically, if you can't afford it, you just go for all the government ones. They will be slower in appointment. You will have less appointments generally, less intensity of care because there are just so many. And then some will default follow-up because it costs money to travel to and fro to hospital. You have to not work for the day if you're on daily wages. If you're on monthly normal salaried positions, then you would be able to take a day off to come to hospital. I mean, the situation, let's say if it's a foreigner, that sort of situation in Malaysia would arise only in a foreigner. In a foreigner, I've had a situation in a refugee who did not want his 32-weeker to be resuscitated. We said why? He said because they can't afford it and they didn't plan this pregnancy. So I said, well, if the baby comes out alive, then we will have to do, like give him minimum support. If you don't want him to be ventilated, and we understand you can't pay, then we'll see how it goes. But in my mind, I was thinking that this baby probably will just survive on CPAP. So the baby did survive, and they were actually upset that the baby did not die, and that they have to pay the the few weeks of care. So in the end, they asked for at own risk discharge. Now that is the ethical problem because, like, on the one hand, if we're talking about child rights and child lives, we actually can stop the parents from taking the child home. But what happens then is the child will be left with us, and we have nobody to pass the child to, and the child will be sent to a welfare home and basically lead a rather miserable life. So actually we let the parents take the child home. It was a difficult decision, but we sort of like discussed among a few of our consultants. So I presume that the child would have been breastfed, but we don't really know what happened to the child because they didn't come back for follow-up.
That's really helpful. So I was going to ask, Munira Maslan has a question. Munira, would you like to ask Irene your question?
Can you speak louder because I have problem hearing just now the Dr. Gautam's.
Hi, Irene. I think it's following what we were just mentioning just now. I was wondering, the mortality data that you were presenting earlier, does that include like the undocumented migrants, the foreign workers, children who might not present to hospital or present later on after the baby's been born and not survive?
Are you talking about the neonatal mortality rates and all those, the graph that I showed?
Yeah. Whether it could be actually higher if there are a lot of undocumented ones.
The initial years, we are not sure. Most likely it did not include. But the final, would say since 2010, there was an effort to collect those. But of course, we will miss those that are home deliveries and home buried and never came to light. Munira, are you from Malaysia?
I am, yes.
So, Irene, one more question that we had in terms of kind of following perinatal optimization strategies. I mean, one of the challenges for us, especially in India, was how good our antenatal steroid coverage was. And in particular, magnesium sulfate obviously has just started finding its feet even in the UK. We're not so good at it at the moment. But I'm just curious how you implement that and whether you have any national drivers for perinatal optimization in preterm care.
We worked very hard for the antenatal steroids. The midwives were allowed to give the first dose before sending the mother to the nearest hospital. So I think that our coverage of first dose antenatal steroids is about, well, I wouldn't say it's really excellent, but it's about 70 to 80%. Our second dose is not as good. At least this was when I last looked at the data, a couple of years back. It's about 60%. But again, like the private hospitals, they are 100%. The hospital, the ones in the some will just come in and deliver. You don't even have time. You just have time to just give the first dose of the antenatal steroids, and they're delivered in half an hour.
I mean, realistically, you're absolutely right. I mean, our data, we only achieved 89% last year for our first dose. And for the second dose, again, it went down to about 75%. So clearly, even in our setup, which is, high income developed, I think you're right. The challenges of trying to get steroids in I mean, that I would say those figures are really good. In terms of kind of infection in the neonatal unit, and that is obviously a major challenge for us. And the use of
a challenge for us too.
So, I mean, just in terms of climatic conditions, the humidity and heat in Malaysia, how do you manage those things? Because clearly that's something that we don't have to deal with, in that, we rather have to keep our NICUs warm, but heat.
Our NICUs are cold. The new NICUs are all cold. The older NICUs are just nice, about 26. They're all air conditioned. Except for the special care. I mean, I'm talking about the state hospitals. The district hospitals, the special care nurseries may still be fan, and that is good because the babies don't have to worry about being hypothermic. In fact, our major problem is prevention of hypothermia from delivery in the labor room to an OT to NICU. 50% of our babies are actually below, the temperature is less than 36 degrees.
That's fantastic. I'm going to just open the floor to any last questions that my colleagues might have for Dr. Cheah.
Yeah, I think, most of the chat ones have been answered, is it?
Yeah, we've gone through most of the check ones. So just a last question from one of my senior trainees over here. So the availability of drug surfactant. And I mean, is that in government hospitals? Do the families have to pay or fund that, or is that something that the government hospitals are able to fund?
No, this one all funded by the government.
That's amazing. Okay.
Yeah, we are in well, it's like our care is expensive, but the charge to the family is very little.
Sure.
And I don't know how long we can last.
I think that's very humble. And, I think with what is happening in India at the moment, we spend only 1% of our GDP on health in India. And I think we're starting to see the difficulties now, with the management of COVID and how overwhelmed our hospitals are. So, I think admiration goes out to how you've managed things over there. And I would like to take this opportunity once again to thank you for such a lovely and insightful talk to all the participants in our course and our network. We're extremely grateful. Uh, Thank you so much.
I hope it was relevant to you all, because I was just wondering whether it was relevant to know,
I think it's very
detail.
important. And I think the reason it's very important is because we get families, as we discussed, from countries like India, Malaysia, China, say, for example, who come here. And we don't realize that when we resuscitate a preterm baby and that baby has to go back to its home country, the difficulties the parents might have to go through because of cost constraints, income constraints, transport, private
I
transport.
think that the family is worried as soon as the baby starts to you have to pay in UK, because they're so used to things being relatively free in terms of health. Although I must say that many of our patients, especially adult patients, they access private hospitals now because of private insurance, because of insurance. So many actually can attend private hospitals, but health insurance doesn't cover neonatal care as well. So only a few people who are lucky enough to have worked in like the big corporations like Maybank and all that, they can claim 100,000 ringgit from from the employer if they are in executive level.
Just signing off for our trainees, I was going to say, a very important aspect is that if we get any private patients from countries who are not British citizens and registered with the NHS, emergency care for delivery of the mother and for management of the baby, the ventilation, the emergency management is completely free. But once the baby goes on to special care, say, for example, in a situation where it can be repatriated back to home country, the patient then has to privately fund that. And the biggest cost in those situations is the cost of transporting the baby back to the home country, which a lot of parents can't afford. And as Irene has mentioned, for some countries like Saudi Arabia and UAE, they will fund the transport, the government will fund it. But for other countries, it's for the parents to fund. And if they don't have travel insurance that covers that, which is often the case, it can put them in a very, very difficult situation. And that's where we then have to approach charities to try and fund some aspects of that. And we do have air transport services, which are charitable in the UK, who help in such situations. Thank you so much again, Irene. I'm so grateful.
Thank you, Alok, for inviting me. Hope you all enjoyed it. Yes.
Take care.
Thank you.